Hi, everyone. Good morning. I want to welcome you to our session on race, ethnicity, language, sexual orientation, gender identity data collection. We have Morgan Black here. I'm so excited to have Morgan here. She has over 7 years of experience in the healthcare quality and health equity areas in government, nonprofit, and she's the director for the Advancing Healthcare Excellence and Inclusion Program. And helps New York hospitals improve their patient sociodemographic data collection. So I am very excited to hand things over to Morgan. I met her at the American Hospital Association conference in Minneapolis this past year and was just very eager to expand her knowledge and her reach of her knowledge to others so that we can all do better. So I'm going to go off camera and hand it over to Morgan. Welcome.
Thank you so much, Dr. Pratt Chapman, and thank you, everybody. I am so excited to be here with you all today. All right. So I'd like to begin by sharing a little bit about myself. So as Dr. Pratt Chapman mentioned, my background is in clinical quality improvement. And so during my time at the Mount Sinai Health System, I worked at their main hospital located on the border of the Upper East Side in Harlem. And my team did a lot of data analysis. And so I found myself stratifying patient outcomes data by race and ethnicity. And I became really interested in SOGI data as well when I was working on a project with Mount Sinai's Center for Transgender Medicine and Surgery. So that really sparked my interest even before I was working directly with that type of data as a main component of my role. So then at the beginning of the COVID-19 pandemic, I joined a local health department in Washington State in a role that required a deep understanding of the population. And the health department had a really strong health equity focus and used real data to inform their geographically targeted community outreach in the months leading up to the vaccine rollout. So I kind of got a bit of experience there as well, which leads me to my current role. And so I'm currently the director of the Advancing Healthcare Excellence and Inclusion Program at the Healthcare Association of New York State, also known as HANES. And my team works with a cohort of 36 New York hospitals to help them identify and address disparities. And our hospitals improve the collection and use of real SOGI and SDOH, social determinants of health data. They build partnerships with community-based organizations that are working to address the same issues as them. They implement best practices in DEI, and they align their work with health equity regulatory requirements from CMS, from the Joint Commission. And, you know, as requested by Haney's guest speaker policy, I do have to state that the views, information, content, and/or opinions presented are solely those of the author, myself, and do not represent the policy or position of Haney's. So today I want to talk to you all about the data components of my work, specifically how to optimize real and SOGI data collection. And so, you know, apologies if this is pretty basic, but I want to start with some definitions here for some terms that are going to come up a lot during the presentation. So first, REAL stands for race, ethnicity, and primary language. And SOGI stands for sexual orientation and gender identity. Healthcare disparities, I like this definition, are preventable differences between population groups defined by sociodemographic characteristics, such as REAL and SOGI. And disparities manifest as differences in life expectancy, mortality, disease, and disability. And in the hospital setting, you can identify disparities by looking for preventable differences in health outcomes and patient experience. And then data stratification, which we're only going to focus on a little bit in this presentation, but data stratification is the process of separating data into distinct or non-overlapping groups. And so where that comes into play is when you're comparing quality outcomes such as readmissions or patient experience across sociodemographic groups. Data stratification is kind of how you start identifying those disparities. So let's talk about our why. So the purpose of collecting real and SOGI data is to remove barriers to optimal health. And so we recognize that these barriers are often structural or systemic, and that a hospital can't dismantle them alone. But collecting high quality patient demographic data helps us understand who our patients are and it helps us identify disparities in health outcomes. It motivates us to identify the drivers of those disparities. It helps us connect with community partners who are working to address the same issues as us. And it helps us customize our interventions to best meet our patients' needs. So how do we understand our whole patient population? We ask every single patient about their race, ethnicity, and language, and sexual orientation and gender identity. So what I want to do now is kind of walk through step by step the process that we use at Haney's with our hospitals to help them kind of get through the project of optimizing their real and SOGI data. And the first step is leadership engagement. And this step is extremely important because I've had so many conversations with hospital leadership where they want to jump right into the data stratification component of this work. And I've really had to just say, okay, let's pause, let's take a step back. There are some questions I need to ask you first. There are some things we need to kind of figure out before we jump right in. And so you want to be asking questions like, for example, who from leadership is responsible for the collection of real and SOGI data? You know, who's accountable? Which data elements do we collect? And are they standardized across different locations, across different care settings? Which roles are responsible for collecting this information? So for example, is a patient access person or registration staff, are they responsible? Or does it come down to the nurse during the intake process? Is it up to the patient to provide this information before they even come to their appointment? How does that work? And then who can see the data? How do we validate the data? How do we measure improvement? All of these are questions that you need to ask before you start analyzing data. And that will really tell you, these questions will really tell you what the gap is and what work you need to do before you jump into data analysis. And so, you know, oftentimes leadership is not going to have answers to all of these things, and that's fine. You can actually use the gaps in your information at this stage to think about who else you need on your interdisciplinary team. So, for example, somebody from IT can help explain where information lives in the patient's chart. They can help kind of explain the flow of information and kind of how it's documented if you have different EMRs, or, you know, if the workflow looks different in different care settings. A patient access supervisor and a nurse manager might be good people to have on your team because they can help you design that workflow, and they can help you understand kind of what's realistic for their staff. And then a data analyst is obviously super important to help you develop internal reports. You want to make sure that you have an accountability structure and that different departments can see how well they're doing with data collection. And the data analyst can also help you validate the data. They can help you figure out how to measure improvement. Because, you know, if you're in a project leadership position, you probably don't want to be doing all of these roles yourself. So that's kind of how you want to start, by assembling your interdisciplinary team and understanding kind of what level of knowledge folks have going into this. So your next step is to begin to develop a standardized workflow for data collection. And so I'm going to start here, and then we'll talk about real data and we'll talk about SOGI data. So what you want to do is begin by listing out all of the data elements that you want to collect. And you want to determine the order in which questions should be asked. So these screenshots here are from New York Presbyterian. They choose to collect ethnicity data before race. But it's really up to you how you want to organize those questions. You just want to make sure that users can select multiple options for race. And so once you figure out the data elements that you want to collect, your team should really walk through each step of the patient journey and kind of make a map. So when the patient is at home before their appointment, do they have an opportunity to provide the data? When they come in, is there a chance for them to enter the data, you know, at registration, at a check-in kiosk, on a paper form, anything like that? You know, when they meet with the nurse during the intake process, are they asked to provide their real data, their SOGI data? You know, so with that patient journey map, that really tells you what touch points the patient has with each staff member. And then you can figure out from there which staff member should logically be responsible for collecting the data. And so I'm not necessarily telling you, here's exactly where real data should be collected, here's where SOGI data should be collected. It's really, it depends on the workflow that you have in your department, in your hospital, in your facility. And that's okay. Things don't necessarily have to be done the same at every organization. We've found that that it works just fine if it's kind of customized to your facility. So let's talk about real data specifically. So when you're developing a workflow for real data collection, you typically want to collect real data during the registration process at the initial visit with your patient, and then you want to update this information each year. And so there are a couple of ways that registration staff can ask about real data. And we recommend this first question here to provide our patients with the highest quality of care. We're asking all of our patients about their race, ethnicity, and preferred language. How would you like your race and ethnicity recorded in our system? And then, following up about preferred language. We like that because it includes the why. It shares, why we're asking you for this information to begin with. Of course, it's perfectly fine if you want to break out these questions one by one and say, okay, are you of Hispanic background? Yes or no? What race do you associate with? And what is your preferred language? Now, SOGI data is, we also recommend collecting SOGI data at the initial visit and updating it annually as well. And I really like this graphic by the Fenway Institute, because it recommends that, patients have the chance to input SOGI data at multiple touch points throughout their journey. So starting at home, if they're able to log in through like a patient portal or something like that and provide that information, then during on-site registration, ideally through a kiosk or through a form, and then in conversation with their provider. All three of those are the recommended touch points for collecting SOGI data. And so I want to share these recommended questions. They're used by the Mount Sinai Health System, and they ask their patients to provide more than just the basics of sexual orientation and gender identity information. And so the reasons that they give for this are, that asking for current or preferred name and gender pronouns is a really good start to this conversation. It also ensures it ensures that you refer to every patient correctly, and it tells your patient, we respect your identity, we want you to feel safe here. And so then asking about sexual orientation really provides helpful context for any counseling conversations about risk reduction. Asking about gender identity can lead to, if it's relevant, discussing a gender transition potentially. Asking about the genders of a patient's sexual partners can start a conversation about sexual practices and reproductive health. And then asking about sex assigned at birth helps you understand what organs might be present in the patient's body so that you know what follow-up questions to ask. And so really, you want to make sure that your staff are also able to explain, why this information is important to have on the healthcare side, as well as, why we're asking. And so, SOGI data is, it's interesting because sometimes staff are a little more uncomfortable asking for this information. Depending on your patient population, some of your patients might be uncomfortable providing this information for a number of reasons. Some LGBTQ+ patients might not feel comfortable providing SOGI information because they're worried that they might be discriminated against because of their identity. And other patients who might be, heterosexual might, just be uncomfortable for other reasons, thinking that people might assume that they are LGBTQ+, and they might be offended by that. That doesn't happen very often though. And so I think, when you're talking to your staff about collecting SOGI data, it's important to kind of address their concerns, hear them, but tell them that, patients really aren't often offended by being asked for this information. And you just need to make sure that you're able to explain why you're collecting it and why it's important to ask for this information to begin with. And so I want to talk about staff training now and some of the ways that you can make sure that your staff are comfortable asking for this information while making sure that your patients have enough information so that these conversations are productive. And that brings us to We Ask Because We Care. So our hospitals used the We Ask Because We Care campaign to train their staff and to engage patients in conversations around demographic data collection. And so We Ask Because We Care is a national campaign to improve the collection of race, ethnicity, and language data. And we've also adapted it for SOGI data as well, and we found that it's just as effective. And so this is a poster here from the Henry Ford Health System, who created We Ask Because We Care. It says, what is your race? What is your ethnicity? What is your preferred language? And then over here, we have another poster from the New York Presbyterian Dalio Center for Health Justice. Because it is a national campaign, anybody can create materials using the We Ask Because We Care slogan. Just for more information about We Ask Because We Care, I would recommend reading Building the Foundations of Equitable Care by Amelia Shapiro and her team at New York Presbyterian. It kind of goes through the study that they did with this program. So really the goal of We Ask Because We Care is to lead to conversations where you have an opportunity to build trust with your patient and say, we want to learn about you because we want this deeper knowledge of who our patients are so that we can better serve them. So I want to go back to some of the common staff concerns. And so the biggest thing that I've heard is that, staff are worried about whether patients will respond well to being asked for real and SOGI information. And so I often reference these 3 studies. And in the first one, in a survey of about 1,500 patients, 90% responded that they are willing to answer SOGI questions. So that's really good. Another survey of 301 questions, 77% agreed that SOGI data is important for their medical provider to know. That was back in 2014. So, opinions may have shifted. We'll see. And then in the third survey of 220 patients, 80% agreed that providers should collect race and ethnicity information. So I like to reference these studies just to say, it's not the number of patients that kind of push back on you might be lower than you think. Occasionally, a patient will respond poorly to being asked to provide real and SOGI information, and that's where you want to deploy your We Ask Because We Care materials. You want to make sure that your staff have a few sample scripts on hand that they can reference, along with some patient FAQs to guide conversations. We put those together for our hospitals. They're available on our website. And you also want to provide some patient education materials so your patients can learn more. So really you want to take the pressure off of your staff members, for handling any conversations that don't go as well. You want to have them be able to say, okay, it's okay, you don't have to provide this information if you don't want to, but I want to share some, some background on why I was asking you this to begin with. The staff member would hand the patient a brochure and say, it's part of our We Ask Because We Care campaign. We're trying to learn more about our population so we can best serve you. Then there's, kind of the second level of this, which staff are really worried that they will say or do the wrong thing. This is a common concern. It most often comes up in conversations about collecting SOGI data or working with transgender, non-binary, and gender non-conforming patients. And so I want to share some recommendations from Dr. Barbara Warren, who is the Senior Director of LGBTQ+ programs and services at the Mount Sinai Health System. So, mistakes do happen, but you can definitely train staff on some simple ways to avoid misgendering somebody or using the wrong name. And so the first recommendation here is to use a warm handoff. And this can just look like a simple introduction. So, let's say it's the end of your shift and, you want to introduce your patient to the new clinician who's going to be taking care of them. You can say, for example, this is Morgan. She uses she, her pronouns. That's it. Then, the new clinician who's coming in understands how the patient wants to be referred to. And you can teach staff to verify a patient's legal name without misgendering them too, if their legal name is different from their preferred name. It's really just about being kind of tactful and, having these conversations quietly or, referring to a piece of paper as opposed to asking your patient to say their legal name out loud. And staff can also learn to anticipate barriers that LGBTQ+ patients might face as they interact with labs or pharmacies or insurance. And staff can work with each patient to address these issues. So I think a lot of the staff concerns here about, potentially doing the wrong thing or putting their patient in an uncomfortable situation, you can really, help your staff feel more comfortable if you say, all right, here are some ways that you can actually be proactive when you're working with your patients to make them feel welcome, to make them feel like, you're on their side and you have their best interests at heart. But yeah, these are some common staff concerns that come up. So it's good to just kind of anticipate them. So at this stage in your project, you may run into a few common challenges. Now in quality improvement, we love reframing challenges as quote unquote opportunities for improvement. So that's what we're going to do now. And so if you're having trouble figuring out where to fit patient self-reporting into your workflow, you can think about the information that your patient provides during the check-in or registration process and incorporate real and SOGI questions into any paper forms or patient-facing screens, check-in kiosks, or online portals. Patient reported information is, it's extremely important to make sure that the patient has a chance to provide that information on their own, and that it doesn't all come down to the staff asking questions verbally. Now, if patients are not responding to real and SOGI questions and staff are not capturing the data, you might get a lot of blank real and SOGI data fields. That's a pretty quick fix. You can make sure that the fields are required so that, if somebody is asking a question on real or SOGI data, they have to select something as an answer. They can't just leave it blank. You just have to make sure that you include decline as an option, and then just let your staff know it's okay if your patient declines to answer. We're just going to keep asking them once a year, and they will have this information available to fill out online if they so choose. And then if a lot of your patients are declining to answer, that's an opportunity to provide some patient education. So we go right back to we ask because we care. Maybe you have a chance to hang up some posters and distribute some flyers or brochures. Maybe you have a chance to send out an email to your patients in general about the We Ask Because We Care campaign. You can invite them to fill out their information online and explain why you're doing this. But it's also, an opportunity for staff training to say, okay, so are you guys asking the questions to begin with, or are you selecting decline because it's easy and you want to get through your workflow quickly? We want to assume that our staff are following every step, but sometimes you have to ask. So I just want to emphasize the importance of collecting self-reported data. Your patients are the experts on themselves, and they are the most accurate and consistent source of real and SOGI information. And they're more likely to select the same categories to describe themselves over time compared to employees who are making assumptions or guessing. This is an issue that we run into a lot is, figuring out whether your data is actually patient self-reported data. So I'm going to talk more about that here in a second. So just going through some lessons that we learned in the process of working with our 36 hospitals. So data validation is key to making sure that all real and SOGI information is self-reported. And it's not an issue as much when patients provide the information themselves online or on a paper form as they're checking in. But when patients are asked to verbally confirm real and SOGI information, there are a couple of ways that you can ensure that the data is self-reported. You can do observations, you can sit in the waiting room and just listen to conversations that are happening between registration or patient access staff and the patient. You can also ask your staff to show you how they collect real and SOGI data. And that's always good. It's kind of like a teach back method. If you say, hey, can you walk me through how you would have a conversation with the patient? Or, pretend I'm the patient. Can you ask me to provide real and SOGI information? That tells you a lot about what workflow your staff are using and how comfortable they are with those questions. So then when measuring improvement, you should have a goal in mind for the % of patients with real and SOGI data in their chart within the first year. Now, this goal really depends on your organization. Our hospitals typically set a goal that 90% have real data documented and that 80% have SOGI data documented. And the reason that the goal is higher for real data is because most of our hospitals were already collecting real data when we started this work. But some hospitals were not collecting SOGI data at all. So being realistic, looking at where you're starting really helps you set the goal for where you want to end up. And so you want to track documentation compliance at the department level. And you want to make sure that departments are reporting out their progress to leadership, just so there's kind of that accountability structure. So over the next few slides, I'm going to talk about a couple of red flags that our hospitals identified during their data validation processes that led them to adjust their workflows and improve their training processes. And so we'll kind of talk about each of these as a case study. So in our first case study, our hospital leadership shared that 99% of their patients had race and primary language information documented in their medical record, but only 62% of them had ethnicity documented. And so they were confused. They wanted to know why this was happening. And so we met with them and we said, okay, have you had a chance to sit down with your staff and ask them about how they collect this information? Have you had a chance to do any observations? What can you kind of tell us about the workflow that's currently being used? And so the hospital staff said, we'll get this information, we'll get back to you. So we asked the patient-facing staff to kind of walk us through their data collection process, and we found that the data that they were collecting were not self-reported. And so apparently the staff said it's harder to figure out someone's ethnicity than their race or preferred language, which of course is wildly problematic. We don't want to be guessing any of that. We don't want our staff to be just looking at somebody or listening to somebody and writing down their best guess. So the hospital ended up doing another round of training on collecting patient-reported data with an emphasis on asking and never assuming. And, going back to we ask because we care, the hospital also distributed patient education materials to help their patients feel more comfortable. And, really kind of doubled down on this. And so we found that, since we made this discovery, the documentation compliance in both categories hovered around like 70-something%, as opposed to 99% for race and primary language. But at least we know that the data that's being collected is, validated, it's self-reported. We know how we got the data to begin with, which means we can use it. So that really told us a lot. We want to assume that the data that's coming in is good. We want to assume that we can jump right in and start doing data analysis, but no, you have to stop. You have to validate the data. So case study 2, this one was really interesting because the hospital came to us with a really puzzling issue. And they said, we've been doing extremely well with staff training and patient education, but still over half of our patients have their race listed as other. What could possibly be happening here? And so this hospital is located in the Bronx. It's got a super racially diverse service area. And so what we decided to do was we wanted to compare our hospital discharge data on race and ethnicity to census data within the hospital's service area. And so hospital data was telling us that 52% of our patients had race equals other in their charts. And then we compared that to census data, which told us that 37% of people living in the service area identified as some other race. So we had an interesting conversation with hospital leadership where we said, okay, there are a couple of things coming into play here. 52%, obviously higher than 37%, so that means there's a gap, between what we're seeing with the data that the hospital is collecting and probably what is actually happening. It means that the hospital can do more staff training and create more opportunities for patients to provide self-reported data. However, 37% is a pretty high number. And so, if 37% of people in the service area identify as some other race, that tells us that that these people don't necessarily see themselves represented on the list of race options provided by the census. And knowing that this is a really diverse area, what the hospital ended up doing was expanding its list of options for both race and ethnicity. And they've seen the percent of patients in the other category fall significantly this year. So we see that as a success, And over here, we kind of have the breakdown between the typical categories provided for race. So white, Black, African American, Asian, American Indian, or Alaska Native, Native Hawaiian, or other Pacific Islander. But then under other, we have, ways that patients were identifying themselves within the race category, such as Middle Eastern, North African, Haitian, Filipino. The list goes on. And the way that the hospital actually ended up expanding their list of options was they gave patients a chance to write in what best described their race under other. And then they took their top 10 responses and actually added them as checkboxes under race. They also did this for ethnicity. And so what they've been able to see is kind of a more accurate picture of who lives in their service area and their racial breakdown and ethnic makeup of their population. So this was a really good learning opportunity for them. So while most of this presentation has been instructional, I do want to share some outcomes from our work with our 36 hospitals in New York. And so in the past year, we've seen some good progress. 100% of our hospitals are collecting self-reported real data, up from 83%. 78% of our hospitals are now collecting SOGI data, up from 39%. And the SOGI data statistic is pretty interesting because, we kind of measured this information through a pre and post-program survey. In the pre-survey, 20 hospitals said that they were collecting SOGI data, but we also asked them to list the data elements that they were collecting. And we found that 6 out of the 20 hospitals that said that they were collecting SOGI data were only collecting male and female for gender identity. And they were only collecting straight/heterosexual and something else for sexual orientation. So as we know, that is not adequate. That does not, that's not, the full list of data elements that we need for SOGI information. So really only 14 of our hospitals were collecting SOGI data last year. Which, now luckily up to 78%. The ones that are still struggling with it have some issues with their EMRs. A couple are switching like from Cerner to Epic, and others are just having a bit of a slow go with it. But this work takes time, so we're hoping we can get everybody up to 100%. 19% of our hospitals expanded their list of options provided for real and SOGI data. So like that second case study, we found especially in our hospitals that serve diverse service areas, that this was their best bet, was to, the best way that they could accurately capture the racial and ethnic makeup of their service area was to provide more options for their patients to identify as. And then across all of our hospitals, we saw an overall 20.4% decrease in patients classified as race equals other. And this is a big deal. This means that everybody, at least that many more patients were, saw themselves represented in the options that were provided for race. So we hope to see more good progress in the years to come. So I want to switch gears here and talk a little bit about what happens after you optimize your collection of real and SOGI data. You're collecting good data, what's next? So we can talk about data stratification and the process of identifying disparities. So data stratification is not terribly difficult if you have good data to begin with. And these tables are examples of ways that you can organize patient satisfaction scores and 30-day readmissions, just as two examples, across different demographic groups to look for disparities. And I do want to point out that the patient satisfaction table doesn't actually include any HCAHPS data. It's just for demonstration purposes, though one of our hospitals is working on a project to stratify HCAHPS data by sexual orientation. We don't have their data to share today. So really, when stratifying data, it's important to not draw conclusions from these tables, but to use the tables to guide discussion and raise follow-up questions that you can discuss with your interdisciplinary team. So for example, looking at this table, I might ask, for readmissions, why is the readmission rate so much higher for patients of 2 or more races compared to patients in other racial groups? We see that our number here, we only saw 50 patients that identified as 2 or more races. So, our sample size is not very big, but still, that's 50 patients where 26 of them came back. That's not great. So, maybe we can discuss this with our group and figure out what's going on here. We can also ask, with our patient satisfaction measures, why does our hospital score so much lower on doctor communication for lesbian, gay, or homosexual patients compared to straight or heterosexual patients? And you can look at these, overall, like you can also look at nurse communication. Why does our hospital score so much higher for nurse communication for lesbian, gay, or homosexual patients compared to other patients, but also why are nurses so much more active at communicating with this group of patients compared to doctors? So there are a lot of follow-up questions that you can pull out of these tables. And, I think there's this conception there's this thought process that we hear from a lot of our hospitals, particularly our smaller, more rural hospitals, our hospitals that don't have a big data team. We get a lot of questions about, okay, data stratification, that's challenging, that's staff intensive, and you see at like conferences and in research papers, you see people pull up their, their Tableau software and say, okay, so all of our information feeds into this program automatically. It can be pretty intimidating when you look at what some of these larger academic medical centers are doing, for instance. But a lot of my job when it comes to data stratification is, reassuring people and saying, I promise you can do this. You can make a table, you can break this down. You can run a report in Epic, you can download the data, you can do this yourself on your computer, it's okay. It's really not that challenging. So data stratification, I wish I could tell you that all of our hospitals are at that stage. I would say like 80% of our hospitals have reached the stage where they're able to, they're confident enough in the quality of the data that they're collecting, where they're able to do some data stratification and compare patient outcomes and look for disparities. But, some of them are still at that initial stage of, okay, we know that our data is improving, but we're not there yet. And so I want to share some of the work that our hospitals are doing at this point, and where some of the data stratification has led. And so one of our hospitals is looking at C-section rates by race and ethnicity. And what they found is that Black patients have higher C-section rates than patients in other racial groups, but that C-section rates are relatively similar across ethnic groups. And so the team, upon finding this out, they had a conversation about, why is this? What's happening? And they went to this list of questions here They talked about, is this disparity the result of clinician bias? Are Black patients being urged to have C-sections at a higher rate than patients of other racial groups? Why could this be happening? They ended up looking at C-section rates by provider. They didn't find any evidence of clinician bias. They discussed, is it indicative of a larger structural inequity? Is this something we can address in the hospital, or do we have an opportunity to engage patients or engage community partners in finding a solution? And, after having this discussion, they, with input from their patients, they ended up reaching out to a local birth justice organization and working together to create a doula program. And so they ended up hiring 6 BIPOC doulas to work in the hospital and provide free services throughout, before, during, and after the birthing process. This went live in September, so we don't have enough data yet to show improvement, but that's just one example of the type of work that can be done from improving your data, stratifying your data, identifying a disparity, discussing it with the team, and coming up with kind of a pilot. And so another of our hospitals is looking at the mental health of LGBTQ+ youth and adolescents. Not surprisingly, they found that this population group has worse mental health outcomes than their straight and heterosexual peers. And so they actually ended up reaching out to a community-based organization as well that does a lot of that work with this group. And they're currently getting some feedback and getting some suggestions from community partners on how they can improve their program, how they can target their services more appropriately to this group, and how they can address their biggest concerns. And then a third program is focuses on social isolation and mental health of older adults living in rural areas. So this is a really good example of kind of looking at how these different components intersect. The hospital found that rural older adults are more socially isolated and have worse mental health than older adults living in urban or suburban areas. This is not particularly surprising, but because they had the data, they were able to make the case. This is a hospital in central New York. They were able to make the case and reach out to a couple of different organizations in the area that do recreational activities geared toward older adults. And they were able to say, okay, can we bring in older adults who live in these more rural areas? And can we engage them in these recreational activities, but can we also offer them health classes and, bring these people together and, focus on addressing social isolation, but also look at some of the things that impact mental health. So they're working on offering some health classes that, focus on self-advocacy, handling chronic disease, polypharmacy, some of the issues that older adults face, and they don't necessarily always have the resources within the health system or just themselves to be able to address them. And so this program was wildly popular. And so that's been going on for, I believe, 3 or 4 months now. But these are all just kind of examples of different ways that different directions that I think some of our data work has taken our hospitals. And it shows us the breadth of the health equity world. All of these different issues, all of these different disparities can lead to so many, really interesting partnerships and solutions. So I do want to leave you with this, before we jump into questions, I do want to leave you with this set of questions here. And after identifying a disparity, I really think that, being able to sit down as a team and kind of critically discuss what are the drivers, who can we involve in conversations about how to address the disparity, and, is it something that we can do alone? Most of the time it's not. So with that, I would like to open up the floor to any questions.